Hello everyone, and welcome to the AEUS ocular ultrasound video. There are many indications for ocular ultrasound, including eye pain, vision loss, or vision change, headache, or ocular trauma. The only contraindication to ocular ultrasound is a known or suspected globe rupture, as placing pressure on the eye for the ultrasound can cause additional damage. Ocular ultrasound is typically performed with the high-frequency linear probe, as the eye is a superficial structure. The eye should be visualized in both high and low gain settings to ensure all potential pathologies are visualized. A tegaderm may be used to cover the patient's eye, with a recent study showing better image quality without a tegaderm, but decreased patient comfort, so that has to be weighed. The video here shows the placement of a tegaderm on the eye. You want to ensure that all of the air is removed to create a good quality image. Additionally, this exam requires a lot of gel to decrease the pressure needed to be placed on the eye and to ensure adequate probe contact. The video on the right shows hand placement. Anchoring is important as pressure on the eye can collapse the anterior chamber, decrease patient comfort, and trigger a vagal response. You want to anchor on the patient's face with your fingers or with your elbow on the patient's bed. The ultrasound machine settings are important for ocular ultrasound. While many machines will have an ocular preset, this is not universal. There are two settings to pay attention to, and they are circled in the middle image. The MI, or mechanical index, should be kept low, as this is the amount of power created by the ultrasound beam. As you can see in the picture of the vascular access setting on the left of the slide, the MI is 0.6, as compared to the MI of 0.1 when using the ocular setting. Various settings and the use of Doppler will further adjust the MI throughout scanning. The TI, or thermal index, should also be minimized, as this is the amount of thermal energy delivered to the tissue and can lead to tissue damage if the TI is too high with prolonged POCUS examination. Once you have prepared the patient for the exam and have the right machine settings, the next step is obtaining an image. You should place the ultrasound over the eye, and you should see an image similar to the one shown. You want to fan completely through the eye to visualize all of the structures. Some of the important structures include the anterior chamber, which lies anterior to the ciliary body, the iris, the posterior chamber located between the iris and the lens, which is a curved hyperechoic structure, the vitreous chamber, located posterior to the lens, the retina, which lines the posterior eye, the optic nerve, which shadows and is a rectangular shape posterior to the eye, and the retrobulbar space, which surrounds the optic nerve posterior to the eye. There are many pathologic conditions that can be identified with ocular point-of-care ultrasound, and we will review many of them. A retinal detachment can be seen on ocular POCUS, and it appears as a medium thickness flap that is tethered to the optic nerve, as you can see in this clip. It may be visualized with average gain, but decreasing the gain may help distinguish retinal detachment from a vitreous detachment. You can ask the patient to move their eye to the left and right, and you can often see a retinal detachment fluttering to help further detect the pathology. Retinal detachments can be broken into macula on and macula off. The macula appears temporal to the optic nerve. Involvement of the macula is critical to determining disposition and next steps for the patients. A retinal tear can also occur in patients and can be difficult to visualize on point-of-care ultrasound, with a paper showing a sensitivity of 48% and a specificity of 82%, which is linked by the QR code on the slide. Retinal tears can also turn into retinal detachments, so a negative POCUS with a concerning history still may require an ophthalmology evaluation. A vitreous detachment is often confused with a retinal detachment, and knowing the differences between the two will help the sonographer tell them apart. It is important to differentiate them because a retinal detachment typically requires surgical management, whereas a vitreous detachment can be expectantly managed. A vitreous detachment can, however, progress to a retinal tear or detachment. On POCUS, a vitreous detachment is often thinner in appearance when compared to a retinal detachment and requires a higher gain to visualize. Additionally, it is not tethered to the optic nerve. Having the patient move their eye will also help improve visualization of vitreous detachment, as it will appear to flutter and swirl, and it can often be associated with a vitreous hemorrhage, which is best seen when the patient moves their eye. A choroidal detachment is much rarer than a retinal or vitreous detachment. The choroid is the layer below the retina, and it can be concomitant with a retinal detachment, so it can present in a similar fashion. This can be caused by an accumulation of blood or fluid under the choroid, causing the separation. A choroid detachment appears thicker on POCUS than even a retinal detachment, so it can be visualized easily in a low-gain setting. It appears dome-shaped and typically originates near the ciliary body, which divides the anterior and posterior chambers of the eye. A vitreous hemorrhage can be visualized in the vitreous chamber of the eye. It is often subtle, so the gain should be turned up. Often the patient will complain of floaters in their vision. A vitreous hemorrhage can be associated with other ocular pathology, such as a vitreous detachment. The best way to detect a vitreous hemorrhage is by asking the patient to move their eye, which should give a washing machine effect as the vitreous hemorrhage swirls within the posterior chamber. A lens dislocation is a posterior chamber pathology. Typically, the lens sits posterior to the ciliary body and has a curved hyperechoic appearance to it. In the setting of ocular trauma or vision loss, the lens can be dislocated and diagnosed by POCUS showing a lens not within its typical location. The dislocated lens often has a more circular appearance as opposed to the curved appearance, as the entire lens can be visualized. It also can be subluxed, meaning that it is hanging down but still attached to its typical location. Focusing on the retrobulbar space will reveal the optic nerve sheath, which appears as a shadow from the optic nerve visualized posterior to the eye. The optic nerve sheath diameter can be measured from outside to outside, as seen in this image, with the normal measurement being less than 5 millimeters across, measured from a point 3 millimeters posterior to the eye. An increased optic nerve sheath diameter is considered a marker for increased intracranial pressure, but there are ethnic variations in pediatric measurements which affect the sensitivity and specificity of this exam. You always want to measure both eyes to compare the two values. A bilaterally elevated optic nerve sheath diameter typically suggests elevated intracranial pressure, whereas unilaterally increased optic nerve sheath diameter may suggest other pathologies such as optic neuropathy. Additionally, the optic nerve sheath diameter can be compared to the eyeball transverse diameter, and this ratio has the potential to be more accurate given it takes into account individual differences in anatomy, with studies showing that 0.25 is a normal optic nerve sheath diameter divided by the transverse diameter of the eye. Optic disc elevation, however, is more specific for increased intracranial pressure and is seen with a convex hyperechoic bump over the optic nerve sheath. Any bulging greater than 0.5 millimeters is considered abnormal, which suggests that if you see this finding, it is abnormal. This has been shown to be more specific but less sensitive than optic nerve sheath diameter for the evaluation of increased intracranial pressure. Central retinal artery occlusion can also be visualized within the optic nerve sheath. The appearance of CRAO on POCUS is seen with the spot sign, which is a hyperechoic dot typically centered over the optic nerve sheath, close to the posterior border of the vitreous chamber. There will also be a lack of Doppler flow on the optic nerve sheath where the retinal artery is. In this case, the operator used power Doppler to increase the sensitivity to detect any flow, as it is more sensitive than color Doppler. We recommend optimizing your Doppler settings on the asymptomatic eye and then assessing the affected eye with those same settings. A globe rupture can be identified on POCUS, but a known or suspected globe rupture is a contraindication to performing ocular ultrasound. On POCUS, a globe rupture is identified by a lack of normal circular contour to the sclera and can lead to collapse of the anterior chamber and decreased globe volume. If you identify a globe rupture, immediately stop the ultrasound examination. There are two mimics of a globe rupture, including placing too much pressure on the eye while ultrasounding, which can collapse the anterior chamber, and a retrobulbar hematoma, which can distort the architecture of the eye. A retrobulbar hematoma is seen in the retrobulbar space. It is typically caused by ocular trauma. It can either appear anechoic as the blood initially collects, as is seen in this video, or it can appear hyperechoic as the blood clots within the space. As previously mentioned, it can distort the shape of the eye, leading the eye to take on a guitar pick shape, hence the associated guitar pick sign. Wrapping up ocular pathology, a foreign body can be seen on point-of-care ultrasound. Foreign bodies are hyperechoic on ultrasound, and depending upon the composition can appear differently. A metallic foreign body may have a reverberation artifact, as seen in this video, versus a wood or plastic foreign body that may have a clean shadow posterior to the hyperechoic foreign body. A foreign body that can be normal within the eye is a cataract lens, which appears more linear than a normal lens, with two bright hyperechoic areas on the ends. This is important to note as a post-surgical variant, and as with a normal lens, it can also dislocate or sublux. The pupillary reflex can also be evaluated on POCUS. To do this, you want to flatten the probe against the eye, directing the ultrasound beam across the ciliary body and pupil. As seen in the clip, as you shine light into the eye, you should see constriction of the pupil. This is a good way to assess for the pupillary reflex when the patient has swelling of the eye, which makes it difficult to open the eye. In conclusion, ocular POCUS is an accurate diagnostic tool for patients with eye complaints. You want to use the linear transducer and ask patient preference regarding tegaderm application. The exam should be performed in high gain for vitreous pathology, low gain for retinal pathology, with a low mechanical index. The only contraindication is a known or suspected globe rupture. Thank you.